am Krish Prabhugaukar from Nirvin Life Sciences. On behalf of Nirvin Life Sciences, I welcome you all for this live webinar on marrow transplant, a revolutionary approach for the management of hematological disorders. I extend my warm welcome to our guest speaker for today, Dr. Ganesh Jaishatwar, our chief guest for today, Dr. S.P. Verma, our moderator for today's program, Dr. Amit Khurana, and all the eminent discussants present on this platform. I now request Dr. Amit Khurana to take up the session. Thank you, sir.
Thank you, Mr. Paresh. Can you see my slides?
Yes, sir.
Yeah. A very good morning to all of you who are from India, and good afternoon and good evening from rest of the world. Today, our guest speaker is Dr. Ganesh Jaishatwar from Hyderabad. He will be lecturing us on BMT, a revolutionary approach for the management of hematological disorders. This webinar is brought to you by Mumbai Hematology Group, supported by Nirvin Life Sciences and managed by Perfect Square. I thank Mr. Paresh Prabhugaukar and team Nirvin Life Sciences, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Professor Dr. Shailendra Prasad Verma from Lucknow, our guest speaker, Dr. Ganesh Jaishatwar from Hyderabad, all our discussants who are themselves eminent hematologists or medical oncologists or transplanters, and you participants for sparing your Sunday morning and afternoon and evening if you're from the rest of the world. Do not forget to visit our website, www.magindia.com, where you can access all our future activities. Next Saturday, that is on 24th of September 2022 at 7 p.m., we have got an excellent lecture by excellent speaker on AL amyloidosis by Dr. Vaishali Sanchorwala. And the next day, we have a lecture that is on Sunday, 25th of September 2022 on high-risk myeloma by Professor Dr. Maria Victoria Matios. It's my privilege to invite our discussants and introduce our discussants. We have a galaxy of them, starting with Dr. Abdul Majid Karuwa Dangal. He's a professor and head Department of Family Medicine, Government Medical College, Kochikode. Dr. Aditya Jandial is hematologist, Department of Clinical Hematology and Medical Oncology, PGI Chandigarh. Dr. Anupama Chagya, she is consultant clinical hematologist from London, Northwest University Hospital, NHS Trust, London. Dr. Mona Vijaran, consultant clinical hematologist, Sahara Hospital, Lucknow. Dr. Mukesh Sanklecha, consultant pediatrician at Bombay Hospital Institute of Medical Sciences, Mumbai. Dr. Nakul Tikare, senior resident, DM Clinical Hematology, All India Institute of Medical Sciences, Bhubaneswar. Dr. Nidhi Dikshit, MBBS, MD, PDF in Clinical Hematology, associate consultant, Apollo Hospitals, Kolkata. Dr. Omkar Khandkar, he is consultant pediatric hematologist, oncologist at Bombay Hospital Institute of Medical Sciences, as well as he is assistant professor at Department of Pediatric Hematology Oncology at TN Medical College and BY at Nair Charitable Hospital, Mumbai Central, Mumbai. Dr. Prantar Chakraborty, he is professor, director hematology in BMT at Amri Hospital, Mukundapur, Kolkata. He is also consultant hematologist at Vivekanand Institute of Medical Sciences, Kolkata, Fortis Hospital, Kolkata, as well as he is senior consultant Center for Digital Care Technologies at Macau. He is also ex-professor and head hematology, NRS Medical College, Kolkata. Dr. Shruti Kakkar, she is associate professor, Department of Pediatrics, in charge pediatric hematology oncology at Dayanand Medical College and Hospital, Ludhiana. Dr. Stenin Bala, he is associate professor, Department of Medical Oncology at Nizam's Institute of Medical Sciences, Punchakatta, Hyderabad. It's now time to invite our special guest for the day, Professor Dr. Shailendra Prasad Verma. Just to introduce him, he is MD in Medicine and DM Clinical Hematology, Additional Professor, Department of Clinical Hematology from King's George Medical University, Uttar Pradesh, Lucknow. So over to you, Dr. Shailendra Verma, for your words of wisdom.
Hello and good morning to one and all. At the outset, I would like to thank Professor M.B. Agarwal, sir, for giving me this opportunity to be the chief guest on for this program, and Dr. Amit Khurana for the nice introduction. It gives me immense pleasure to address the august audience and the participants in inaugurating this CME on this Sunday morning. which is being attended by participants from not only from India, from the many other countries of the world. In my brief address, I would like to say something to our young, upcoming hematologists, or those who are interested in making their career, hematology, making their career in future, or just started practicing hemato-oncology. So we see that hematology is one of the ever-growing specialty of medicine, which has seen tremendous landmark progress and development in this field. We have seen CML patients being treated with hydroxyurea and busulfan, and currently we are enjoying the availability of highly selective and highly effective drugs like tyrosine kinase inhibitors. And not only that, for the very difficult cases of CML with T3155 mutation, we have ponatinib and newer drugs like asciminib coming up. Similarly, in CLL, if we see, the drug of choice used to be chlorambucil and steroid at some time, and now we are again having targeted therapies like BTK inhibitors. Not only in the field of hemato-oncology, but even in benign hematology also, we can see there has been a lot of development in near future. Like hemophilia, we used to treat with FFP and plasma initially in 1950s and 60s, and currently we are having much more advanced recombinant molecules along with extended half-life, and even non-factor therapies for rebalancing hemostasis like imicizumab and fitusiran, which are going to come up. Similarly, we have much improvement in transplantation technologies and types of transplants, which now we offer to our patients, and that will be discussed in great detail by our guest speaker today. So we have seen even improvement in newer drugs coming up in PNH and rare disease like PNH, and also many hemolytic anemias like sickle cell has many drugs coming up in treatment modality. So this has been possible because of the better understanding of the molecular techniques, the pathophysiology of the underlying disease, the definitive mutations which are driving these disorders, and this has been because of the extensive research in the field of hematology which is going on. So I would just like to say that hematology, hemato-oncology, and oncology, these are the branches which have the potential of ever growing research, because newer molecules are coming up day in and day out. Once you miss these progresses for 3 months or 6 months, you just come to know that you are far behind from the others who are making pace with all these developments. Treatment of hematological malignancy in hemato-oncology in current era, they are best examples of personalized treatment as well as precision medicine, which we know that this is going to be future of medicine. So everyone is looking for precision medicine and personalized medicine, so that we have the maximum benefits to the patient and least toxicities of level of toxicities. So keeping pace with all these developments is not easy, because this is happening worldwide, and in this area, in this endeavor, the whole information which is being made available to us, to all of you, by the CMEs. And for that, I would like to say that Professor M.B. Agarwal sir has been pioneer in this area, so making this knowledge available to all of us. So I have been attending the National Hematology Update, you all remember, in Mumbai annually, that is from 2007, 2008, and currently the format now is gradually changing in the view of COVID era. So now we have come to more of the online platforms, and these continuous CMEs which are happening on Saturdays and Sundays, they are helping us definitely in keeping pace with the development which is going on in the field of hematology. So that has helped me a lot, and I am very sure that this has helped all of us in totality. So I just want to mention that my best wishes are there for the team organizing this CMEs, and my salute to the entire effort of Professor M.B. Agarwal sir for making this knowledge available to us. And with that, I would also like to just share a happy note that we have got permission from MCI to start 3 DM clinical hematology seats at King George Medical University, Lucknow, from this year onwards. So that is a very happy moment for us at KGM. And finally, I would like to thank for giving me this opportunity to be the chief guest on this morning for the CME. Thank you.
Thank you, Dr. Shailendra, for that great words of wisdom. Thank you so much. Now it's my time to introduce our guest speaker for the day, Dr. Ganesh Jeshwar from Hyderabad. Dr. Ganesh Jeshwar is MD, DM in clinical hematology, and he has done postdoctoral fellowship in BMT from TMC, fellowship in leukemia and BMT from UBC Canada, lead consultant and head Department of Hematology in BMT at Yashoda Hospital, High Tech City, Hyderabad. He is a lead consultant hematologist and head hemato-oncologist, hematologist, and bone marrow transplant physician at Yashoda Hospital, High Tech City, Hyderabad, with over 20 years of experience. He has accomplished over 200 bone marrow transplants performed independently at his center. He completed his MBBS from Nagpur University in 2001, MD Pathology from University of Mumbai in 2006, followed by DM in clinical hematology from West Bengal University of Health Sciences, Kolkata in 2011. He is a member of American Society of Hematology, American Society of BMT, and American College of Physicians. It's my privilege to invite him for his lecture on BMT, a revolutionary approach for the management of hematological disorders. Well, thank you so much. Over to you, Dr. Ganesh.
Thank you so much, Dr. Amit, for that kind introduction. And good morning to everyone, and good afternoon, good evening to people from overseas. It is indeed an honor and a privilege to deliver a guest lecture on this most famous webinar series across hematology, bone marrow transplant in India, led by Dr. Professor M.B. Agrawal sir. It's my privilege and honor. And being a student, younger student in the hematology, it's first time I am delivering a guest lecture, standalone guest lecture. So I will try to, be up to the expectations of the audience as well as the organizers. The topic of today's discussion is a bone marrow transplantation, a revolutionary treatment approach for the management of hematological disorders. I hope my screen is audible and screen is visible and I'm audible.
Yes, please go ahead.
Yeah. So I had no conflict of interest for this topic. And before I talk, again, tribute to the legends, the father of the bone marrow transplant in India, and I'm a proud privileged student of Dr. Mamun Chandi, who started the transplant services second in line after TMH Mumbai way back in 1986 at CMC Vellore. And also, as elaborated by my colleagues, Professor M.B. Agrawal sir, we can call him the father of hematology education across our country for his relentless efforts and his the continuous education programs, which has, I'm sure most of us have our motivation to join hematology thanks to Agrawal sir and his academic programs spanning over last 3 and 3.5 decades. So the outline of my presentation today is I'm going to speak about the little bit of basics and how we have come to the current bone marrow transplant status across and what are the current indications of bone marrow transplant and how we do it, and where the future of bone marrow transplant is going to lead us, and why not only as a hematologist but as a clinicians, physicians, pediatricians, we need to update ourselves with the recent developments in the field, because I believe, and it's the fact, that it's a teamwork. The transplant is a very miniature part of the patients undergoing this procedure led by hematologists, but the lifelong follow-up and care, the responsibility lies on the shoulders of the clinicians, physicians, pediatricians mostly, who follow these patients and who work in collaboration with the primary care hematologist or a transplanter for the success of these patients. So I'll kickstart my presentation with a case. This was a 9-year girl student, class 4 student, who had symptomatic transfusion-dependent pancytopenia. She also had fever, and she was hospitalized a couple of times in other cities, and the previous cultures had grown to our nightmare multi-drug resistant E. coli, only sensitive to colistin. So this was her presentation, symptomatic pancytopenia, and you can see this was in December 2016. You can see she has severe pancytopenia, hemoglobin of 6 grams, WBC 300, and platelet of 10,000. And you look at the peripheral smear, it's just empty with scattered red blood cells and occasional lymphocyte. So with this, we did the bone marrow. It was completely empty marrow replaced by fatty globules. Cytogenetics was normal, and in view of this young age of this girl, this was consistent with aplastic anemia to rule out inherited marrow failure syndrome. The stress cytogenetics was done, which was reported normal, ruling out inherited marrow failure syndrome. So it was acquired idiopathic severe aplastic anemia, in fact very severe aplastic anemia, as the absolute neutrophil count was less than 200. And I like to mind you, she has MDR E. coli on board at the time of diagnosis. So it's a de novo E. coli, MDR E. coli sepsis. So how to treat this case? So this was a medical emergency way back in December 2016, and this was her blood culture growing MDR E. coli. You can see on the culture plate only the colistin impregnation shows some sensitivity. Otherwise, all the carbapenems and the third generation cephalosporins, the E. coli was resistant. So we started supportive care for her, transfusions. We did HLA typing. She was single daughter of the family. She was stabilized in a matter of 2 weeks time. By the time HLA reports and anti-HLA antibody reports came, anti-HLA antibody reports were negative. So she was started on urgent, what you call it as emergency half mass transplant with her father as donor. So we conditioned her with fludarabine, cyclophosphamide, rabbit ATG TBI. This was the first transplant was a TCR alpha beta CD19 deplete haplo. So unfortunately, even after 35 days post-transplant, she continued to be transfusion dependent, severely pancytopenic. All the causes of secondary poor graft function were ruled out, including infections, drugs. Marrow was done, it was empty. The chimerism was 100% recipient. So it was XY chimerism showing 100% XX cells. So the common challenge in half mass transplant, we all know, is the graft rejection. Risk can be up to 10%. So again, she remains to be pancytopenic. So how to save her further? So we undertook her second emergency consecutive second haplotransplant, switching the donor to her mother, and the conditioning was again fludarabine, rabbit ATG TBI. Initially, she received grapholon, and now we have given mega dose of thymoglobulin 10 milligram per kg with a TBI of 2 gray, and this was her second transplant. So she engrafted in a span of, the second transplant was PTCY haplo. She engrafted in a span of about 15 days, and you can see she continued to maintain her count. She has manageable complications, post-transplant CMV reactivation, grade 2 skin and gut GVHD, acute GVHD, which was managed with steroids as well as ruxolitinib. Now you can see her last follow-up till this June 2022. She continues to remain normal with resolved chronic GVHD and no active infections, with complete 100% donor chimerism and a completely normal cellular marrow. So this is almost close to she's nearing 6 years post-transplant and leading a productive life. So what is hematopoietic stem cell transplant? This is unique procedure known to cure vast majority of hematological conditions like hematological blood cancers, immune disorders, bone marrow failure syndromes like this girl, and metabolic disorders. So what we do here, utilize healthy hematopoietic cells from a donor in allogenic stem cell transplant, sometimes bone marrow for benign hematological conditions, mobilize blood most of the times, and cord blood, which is coming down nowadays. I will come to it. Next slide. So the donor, the patient is given conditioning chemotherapy to create a new blood and immune system space for the system, which persists for the rest of the patient's life. So this one of the most advanced curative treatment modalities for vast majority of hematological conditions has been performed over 65 years, since 1956-57, and to date there are more than 10 lakh patients treated with bone marrow transplant. So before we embark on the journey of bone marrow transplant, it is always better to look back to have to move forward in a better way. So the actual, the bone marrow transplant interest across the globe was generated after the Hiroshima, Nagasaki atomic bomb explosions on Japan. So atomic bombs precipitated research leading to the current bone marrow transplant. So initial bone marrow transplant or the experiments were done in mice, and it was mostly in the US defense. You can see growth and continued function of rat marrow cells in X-irradiated mice. The radiation chimeras post-transplant, again, this is from the Atomic Energy Research established from US. The previous one was US Naval Radiological Department. So the major breakthroughs came from these Jacobson's experiments, who had shown that the mice irradiated with lethal radiation and subsequently infused with spleen cells can be rescued and can survive this lethal radiation. Subsequently, Ford's experiments, initially Jacobson considered this to be a humoral factor, but it was Dr. Ford whose experiments proved it to be a cellular component, so hematopoietic stem cells mostly, which repopulated marrow with 100% marker chromosome as of the donor. So the first breakthrough of human bone marrow transplant again came from the father of bone marrow transplant, Dr. Donald Thomas Group at Cooperstown, New York. This was published in NEJM 1957. The surprising fact here, the initial transplants were quite disappointing. 6 patients who had terminal cancers where after a lethal irradiation was transfused with unrelated donor stem cells. All 5 of them, all of them died within 100 days, but only one patient showed transient engraftment. Again, this was the time there was no HLA typing or HLA matching facility available, or was not yet known to us. So again, you can see the conclusion, since the cases for radiation disaster may occur, and since the bone marrow deficiency from radiation or chemotherapy does occur in the normal course of clinical medicine, an effort has been made to determine the availability and usefulness of bone marrow infusions. So this was again the major, the purpose of initial bone marrow transplant was to rescue. And you can see this is a very nice editorial. I'm sure this kind of editorials, when you look back, looks funny. You can see in this 1957 NEJM editorial, in an atomic age with reactor accidents, not to mention stupidities with bombs, somebody is going to get more radiation that is good for him based on these bone marrow infusions and the possible rescue from this bone marrow stem cell infusion. If infusion of marrow can induce recovery in a mouse or monkey after lethal irradiation, one had to be prepared with this form of treatment in man. The leukemic patient who needs radiation and bone marrow and the uremic patient who needs a spare kidney are the people who deserve immediate consideration. From helping them, one will be preparing for the atomic disaster of tomorrow, and it is high time one did. So it looks funny to look. So again, after this initial dismal results of human bone marrow transplant, you can see the late 50s and early 60s, there was significant drop in the number of human bone marrow transplant experiments. And then the one who continued to pursue bone marrow transplants were very few select groups, and the majority of the work initially was done by Donald Thomas and his group once he moved to Seattle in 1962. And they started working on dogs, and subsequently the dog canine genotyping became available. It was serological typing. So this was a picture published. So all these dogs who engrafted successfully, he survived initial immediate peritransplant period. Professor Donald Thomas, who used to stay in a farmhouse, used to take these dogs, and many of these dogs survived to their normal life expectancy, which was about 10 to 12 years. And this was the first dog. You can see newspaper article, Nobel Prize for the test dog. So this was Donna, who survived 4.5 times lethal radiation. That time again, the HLA typing, even serological, was not yet known to us. So probably this dog, by chance, received DLA matched donor stem cells, and she survived, and she lived for 12 years, which is considered to be a normal life expectancy for this dog. So it's quite interesting to go back into the history. So the BMT, the Hall of Fames, the initial 1956, the Jacobson's experiment, which proved that splenic cells can rescue the irradiated mice. Subsequently, first human bone marrow transplant, as I described, by Dr. Donald Thomas. Then 1958, Jean Dosset described the first HLA A gene locus by serological typing. Subsequently, 1960, in Paris, Dr. Georges Mathé, there was a nuclear accident in Yugoslavia. So 6 patients, 1 died immediately who received lethal radiation dose. All 5 patients were tried to rescue with random donor stem cells. All of them survived for varying periods of time. Subsequently, it was found that they received sublethal radiation, probably autologous recovery of their own stem cells might have made them survive this disaster. But this was an important milestone. Subsequently, Peter Medawar, again in the same year, who is considered to be the father of modern immunology, had pioneering work in transplant immunology. The first breakthrough, you can say the first alive transplant or the surviving successful transplant, actually was in 1963. It was way back in 1960s when Professor Damshek sent 2 of his junior colleagues, one of which was Robert Kiley at Dr. Donald Thomas lab in Cooperstown, New York, to learn the procedure of bone marrow transplants. So Professor Robert Kiley spent 1 week there and subsequently came back. And 3 years later, he happened to consult a girl. This was Nancy King, who has very severe aplastic anemia, and the treatment at that time was high dose steroids and transfusion support, but she was deteriorating rapidly. And one of his observations in his outpatient clinic, Dr. Kiley, you can see the Nancy was quite, has Cushing-White faces because of the high dose steroids. But Dr. Robert Kiley, out of interest, inquired the family, and the Bonnie, who happened to be Nancy's identical twin. So how that was proven? So that time again, serological typing was not available. So Nancy and Bonnie's small skin graft from thigh were transplanted on each other, and if they accept the skin graft, it was considered to be a proof of syngenic twin, and they accepted the skin graft. Subsequently, Nancy received first syngenic stem cells from her sister, and Nancy continues to enjoy a healthy life almost close to 6 decades post-transplant. This is the first ever published report of successful allogenic stem cell transplant from a syngenic donor, and it was done at Mayo Clinic, Rochester, by Professor Robert Kiley. Subsequently, in 1968, Professor Van Rood and Paul Terasaki described the modern HLA typing, and in the same year, the famous immunologist Robert Good did his first matched sibling transplant. At that time, again, serological typing was available. So this was done for a 5-year-old severe combined immunity deficiency boy, David, who has 3 sisters, and all the 11 male child in David's maternal family died before David. So it was decided to go ahead with the transplant. So they did typing of all the 3 sisters of David, and one of the younger sister turned out to be full match on serological typing. And subsequently, David went on to receive allogenic stem cell transplant from his sister, and he was first matched sibling transplant of the bone marrow transplant history. Subsequently, the landmark paper by Donald Thomas of first 100 patients of various hematological disorders, mostly the terminal blood cancers, was published in landmark NEGM trial. And it was interesting. All the patients used to be taken into this bunker of the US military where they used to receive radiation, quickly shifted to the ward back. And this was mostly funded by US Atomic Energy Commission. And it is notable to understand that out of 100 patients, only 18 patients were survivors beyond 1 year. Very interesting, even though, it seems quite disappointing today, but yes, that time, by these results, Dr. Thomas continued his endeavors with human transplants, with taking more and more patients earlier in the disease course, leading to better outcomes. The first unrelated donor transplant again was done subsequently within 5 years of first mass sibling transplant in 1973 in Westminster Children's Hospital by Dr. John Hobbs. And this was on a 2-year boy, Simon Bostic, who was a case of, again, immunodeficiency disorder, chronic granulomatous disease, CGD, who at that time there was no unrelated donor registry. This was Simon Bostic's recent picture, and his mother interviewed in one of the British national broadcasting, and subsequently a lot of publicity across newspapers about the request for a typing of voluntary donors, and one of the donors was found to be fully matched with Simon Bostic. Subsequently, Simon Bostic received his first unrelated donor transplant at Westminster Children's Hospital under care of a team led by Dr. John Hobbs, and Simon Bostic continues to enjoy good health even today. So, motivated by Simon Bostic's transplant success, Anthony Shirley Nolan, who was from Adelaide, Australia, moved to UK because her son, Anthony Nolan, has Wiskott-Aldrich syndrome, severe Wiskott-Aldrich phenotype. Unfortunately, they could not find an unrelated full match donor for Anthony, and Anthony subsequently succumbed. But Shirley Nolan continued her quest, and she was the first one to establish the first international unrelated donor registry, Anthony Nolan, based in UK. Subsequently, the other aspects of transplants research continued. Non-TBI conditioning, George Santos, who was the pioneer who first discovered cyclophosphamide and also discovered busulfan in 1983. And in the same year, 1983, first successful autologous transplant for a refractory non-Hodgkin's lymphoma in Steve Bauer was done, who continued to enjoy disease remission close to 4 decades. After transplant, he got married and he led a normal life. And this was probably the first successful autologous transplant in the history. Again, the first, subsequently, the necessity to find donors in patients who didn't have either full match sibling or a full match international donor continued. And Dr. Proxmeyer, who was a researcher, he had a relentless work of close to a decade, and he believed that umbilical cord blood stem cells can be a useful resource for patients who don't have a alternative donor. And then the first umbilical cord blood transplant was done by Professor Ellen Gluckman in Hospital St. Louis at Paris. This was on a child who was 5 years old, Matthew Farrow, Fanconi's anemia patient, who was from Duke, North Carolina, USA, and he and his mother fled to Paris, and he received the first umbilical cord blood stem cells from his matched sister, who was about to be born, Allison. So Matthew and his sister Allison, and Matthew continues to remain disease-free, and he currently works with the umbilical cord blood registries to help patients motivate and create awareness about umbilical cord blood stem cells. Subsequently, reduced intensity conditioning. So this was the wave of 1990s, conceptual wave of 90s. Again, lot of eminent faculties like Shimon Slavin from Israel, Sergio Giralt and Rainer Stroff from Fred Hack. Simultaneous pioneering work from these legends led to discovery of reduced intensity conditioning, harnessing the benefits of GVL for hematological malignancies and making more elderly unfit patients eligible for transplant. Again, in 2003, the reduced toxicity conditioning by way of intravenous busulfan and fludarabine was pioneered by these, again, three different groups led by Martin Bonhoeffer, Claudia Anasetti, and John Dochin. So the breakthrough in 20th century again was haploid identical stem cell transplant with post-transplant cyclophosphamide. This was the pioneering work from John Hopkins, Leo Luznik, and his researcher Ibrahim Fuchs. Thanks to their pioneering work, a lot of haplos for patients who don't have a suitable donor is being done across the globe. Again, reduced toxicity conditioning with triosulfan again was discovered by Enida Nemec in 2011. So subsequently, 2010, the T-deplete haploidentical transplant led by Professor Rupert Hangreitinger from Germany, and subsequently it was taken forward by Dr. Massimo Martelli, Franco Aversa from Perugia Group, and Franco Locatelli and Alice Bettina from Rome, Italy. So hematopoietic stem cell transplant, it is fascinating to just think hematopoietic stem cells, which are rare cells, but very powerful stem cells in the bone marrow, and they can generate the entire hematopoietic system, and which enables cures for vast majority of disorders, not only hematological malignancies and pediatric solid tumors, but n number of non-malignant conditions. And the indications are ever expanding, like marrow failure syndrome, genetic disorders, hemoglobinopathies, immunodeficiencies, and of late, autologous transplant for uncontrollable autologous autoimmune disorders. So what is the aim of hematopoietic stem cell transplant? For malignant condition, it is definitely to permit high dose therapy for effective cancer control, because we know there is a dose versus response effect as per the Gomber's law, and also to induce graft versus leukemia effect, preventing the cancer coming back. And for non-malignant conditions, the rationale is to restore hematopoiesis and to replace defective genes. Yes, we need to think differently. So, in detail, the rationale for bone marrow transplant, replacement of defective marrow cells with normal functioning cells. For example, for SCID, various immunodeficiencies, lymphocytes are defective. And this is the famous bubble by David Vetter of late 60s, who survived up to second decade of his life thanks to this, bubble care. And subsequently, this bubble care was continued across major hospitals in US and Europe, making these children, because prior to this kind of aseptic precautions, these children used to die within first 2 years of life. Thalassemia, where erythroid cells are defective, and you see such expanded erythron by the bony deformities. Other myeloid disorders like CGD, celiac, Higashi disorder, and then aplastic anemia, where all the three hematopoietic cells are deficient. Now, to rescue the marrow from ablative chemo or chemo plus radiotherapy and the graft versus tumor effect, this is mostly for hematological malignancies like high-risk AML in CR1, most of the ALLs in CR2, CML blast phase, we have targeted drugs, so CML transplants have come down, lymphoma, myeloma in relapse setting, and pediatric high-grade neuroblastoma in the relapse setting. In inborn errors of metabolism with a generalized genetic defect, like where the mechanism of tissue damage is buildup of toxic metabolites, and here the donor tissue histiocytes repopulate the affected organs, remove the toxic metabolites, and many a times eliminate or reverse the organ damage. And for many diseases, it is the rationale is to replacement of missing or defective enzymes. So again, going back into the details of transplant, the first transplants, again, I mentioned the milestones in transplant world versus India. The first transplant in 1956 by Donald Thomas at Cooperstown, where the first allogenic transplant in India was done by team led by Professor Yashash Advani sir at Tata Memorial Hospital way back in 1984, where two eminent oncologists, Dr. Advani and Dr. Gopal, were sent in 80s to Fred Huck to learn the the art of bone marrow transplant under Dr. Donald Thomas, they subsequently came back and did their first transplant in 1984 for a 9-year girl of AML. So again, you can see Dr. Kurkure was also part of the team who was trained at Barts, London. The transplant was so difficult at that time. In fact, the actor Sunil Dutt brought all the medicines and catheters from US for this transplant, and Dr. Kirloskar provided laminar, Mr. Kirloskar, the famous businessman, provided laminar flow for the transplant. This girl survived for almost 22 years after this successful transplant from her HLA matched brother. However, subsequently, 22 years later, she died not because of the disease relapse or transplant issues. She had uncontrolled diabetes and pancreatitis. Subsequently, Vellore, the first allogenic transplant was done in 1986 under leadership of Professor Maman Chandian. The boy here you can see, Satyanarayana, was the first successful allogenic transplant for a non-malignant condition. He was the first thalassemia transplant in India in 1991. So coming to the first unrelated donor transplant, as I discussed, Dr. John Hobbs for in UK, Westminster Children's Hospital, whereas the first unrelated donor transplant took a lot of longer time in India. It was done in CMC Vellore in 2006 for a boy with, for a young adolescent with AML who had a long disease control remission, almost close to more than 20 years, more than 15 years post-transplant. Then the first cord blood transplant, as we discussed, was done by Hélène Gluckman and Broxmeyer in Paris, France. The first cord blood transplant, matched cord blood transplant, was done at Tata Memorial Center, again under the team. And the first unrelated cord was done at Apollo Hospital, Apollo Children's Cancer Hospital, Chennai, under Dr. Revati Raz in 2007. So Dr. Revati has maximum number of umbilical cord blood transplants done under her care at Apollo. The first haplo was done across the globe. In fact, it was by Dr. Reiser and Richard O'Reilly at MSKCC in way back 1980s, where the first haploidentical transplant was done in India by Dr. Suparno Chakravarti in 2009 at Apollo Hospitals, Kolkata. The first alpha beta T deplete haplo was done by Rupert Hangrittinger and Franco Locatelli's group in 2010 in Germany and Italy, whereas the first alpha beta T deplete haplo was done in India by Dr. Satyendra Kateva and Dr. Satya Yadav at Fortis Hospital, Gurgaon in 2014. So subsequently in 2016, I had my first alpha beta CG19 deplete haplo. This was a 22 years engineering student who has a CML blast crisis with T315I mutation. He achieved MRD negative CR post 2 cycles of FLAG-IDA in November 25. Unfortunately, while he was gearing up for transplant, he presented with severe headache, CSF has 4,300 blasts. It was a B lymphoid CNS relapse, isolated CNS relapse, which was rescued with triple IT, 2 doses of high dose methotrexate whole blood RT. He achieved CSF MRD negative CR in Feb 2016, and in Feb 2016, I did my first TCR alpha beta CG19 deplete haplo with his father as his donor, and almost more than 5.5 years post-transplant. This was his picture in September 2022, and he's doing well. So bone marrow transplant, as per a common belief, is not scary and not hopeless. For those of most of the August audience here on board are eminent hematologists and transplanters, but there might be many non-hematologists also for them. So what is the logic of bone marrow transplant? What do we do exactly bone marrow transplant? So in bone marrow transplant, to get rid of the diseased marrow, you need to give this high dose conditioning chemotherapy or chemo plus radiotherapy. And as an analogy, this was the air travel way back in 2050s, and this is the air travel in 2022. The similar thing has happened, even similar advances. So this was the way bubble care for transplant patients way back in 70s. This was again Donald Thomas at Frederick's Cancer Research Center, and this is the modern transplant unit. And this is how we manage transplant patients in the transplant unit with all the aseptic precautions and all the neutropenic care. So even the water for sanitary purposes is filtered with this 0.2 micron filter to avoid infection. So there are three important steps in bone marrow transplant. Quickly, the conditioning chemotherapy, which is given to eliminate diseased marrow, prevent graft rejection, and is usually administered over a period of 6 to 10 days. At the same time, the allogenic donor gets GCSF if it is a peripheral blood stem cell harvest for 5 days to mobilize stem cells from the marrow to blood. And at the end of this procedure, the stem cells are collected. This day is labeled at day 0 and infused to the patients intravenously, not in the bone marrow. And the first 100 days is the pre-engraftment period, or period till count recovery. This is the most important part managed in transplant unit with aseptic precautions for profound cytopenia with intense barrier nursing care. And then subsequent post-transplant care, where the role of all the clinicians is of utmost importance, where patient needs periodic follow-up because immune recovery takes time and patient is vulnerable to various opportunistic infections. Again, you can see the cartoon, even though the neutrophil recover earliest, but the T and B lymphocytes take 6 months to 9 months to recover. And during this immune deficiency period, patients are vulnerable for various infections. GVHD, when the graft versus host disease, when the donor stem cells or donor T cells attack the patient's various vital organs and can cause various, mostly 3 organs, the skin, gut, and liver. This is in acute or chronic is like various sclerosing autoimmune disorders. The third is organ dysfunctions arising out of chemotherapy, radiotherapy in the conditioning period, as well as various infections. And always for hematological malignancies, there is always a threat of relapse. It doesn't become zero. Again, after this rigorous exercise, I was sweetly surprised by a visit of one of my patients, very severe aplastic anemia, whom I did transplanted from her match sibling brother 8 years back. And after almost 4 years, she popped up with her daughter. She conceived. She had a normal delivery, and her daughter is almost nearing 2 years now. So donor choices for the hematopoietic stem cell transplant, we all know the, prior to 90s, the transplant was limited to the those having match sibling donors, subsequently with unrelated donor registries. Again, for ethnic minorities like us, the probability of finding full match family donor is 25%, match unrelated donor is 15 to 30%. So essentially 40 to 75% patients requiring transplant don't have a donor. So here comes the role of haploidentical donors, who are immediately available, highly motivated, because the family being the family members, where you can collect any amount of large doses and additional cells for various post-transplant interventions easily available even after transplant. But increased HLA mismatch causes more HLA rejection, more GVHD, more time to immune reconstitution, leading to more infections, and at the same time causes more GVL because of HLA disparity, leading to better graft versus leukemia effect. So actually the hematopoietic stem, the half match transplant goes back to 80s, where the father of half match transplant, Yair Reisner from Israel, has his first PhD topic on hematopoietic stem cell transplantation using mouse marrow and spleen cell fractionated by lectin. So it was kind of CD34 selection, published in Proceedings of National Academy of USA. Subsequently, inspired by his work, Dr. Richard O'Reilly and Robert Good at the MSKCC collaborated with Reiner, and they did their first haploidentical transplant using CD34 selection by these lectin fractions. Again, nowadays DGCI, FDA, or EMA doesn't allow these kind of experiments with sheep red cells and soybean agglutinin for fractionation of CD34 positive cells. Subsequently, in blood, 1983, they published their first 3 successful transplants, haploidentical CD34 selected transplants selected by positive lectin agglutination for children with SCID. Again, this was their first successful T-deplete lectin separated HLA mismatch, HLA haploidentical transplant in a child with SCID in 80s, and this child is doing well. So subsequently, again, nuclear accidents at Chernobyl, Russia. Again, they did transplant from 10 patients, and here out of 10, 6 had unmanipulated stem cell transplant. 4 had T-depleted transplant. Out of 4, 2 survived. So only survivors were T-depleted transplant. So even further, this is again a landmark paper published in NEJM 2014. You can see SCID patients, immunodeficiency disorder patients. You can see the upper 2 curves. If they are taken for transplant, either matched sibling transplant or haploidentical transplant with T depletion, transplanted below 3.5 months of age, the results of T-depleted half-match transplant almost equaling to the results of matched sibling transplant. So again, this Chernobyl nuclear accident was published in NEJM 1989. So subsequently, Reiner collaborated with Massimo Martelli from Perugia Group to they increased their transplants across HLA barriers by increasing the mega dose of CD34 positive cells. And these are the various papers, the landmark paper you can see published in JCO. You can see the leukemia-free survival published in 2005 was close to 45% for for patients desperately requiring transplant, having no donors and having a very aggressive refractory disease. This was promising. Subsequently, the pioneering work by this young scientist Stefano Miltini way back in 90s, you can see the magnet there where he separated the CD34 stem cells by these magnetic beads, which were so tiny, 50 microns of a size of virus particles. But this machine was so powerful, 1.5 Tesla, and this was his first publication. And the first, the rationale or logic for this T cell depletion by these various gadgets was part of the purging technique for advanced pediatric solid tumors like neuroblastoma. So this was actually initially done for stem cell, the neuroblastoma cancer cell purging from the bone marrow cells. So we have come a very long way from early CD34 selection to late 2010 TCR alpha beta CD19 depletion. And these are the graft engineering developments over the last 2 decades of T cell depletion. Initially CD34 selection in 1995 by this machine, and current prodigy in 2021, where not only TCR alpha beta 19 depletion, but also along with retention of effectors NK gamma delta T cells, which have antiviral, anti-cancer immunity, and also CD45 RA depletion, and then subsequent, which are the naive T cells, which are the effector T cells with subsequent post-transplant CD45 RO DLI. The RO are the memory T cells, which are which have selective anti-cancer, anti-infectious immunity, which is causing the GVHD. So the logic is very, very fascinating. You can see on the cartoon, alpha beta T depleted haploidentical transplant. The product is made to run through these electromagnetic beads, which is done in the GMP certified labs, and you can see these the nanoparticle electromagnets retain the alpha beta T cells, CD19 T cells, CD45 RA cells, and then the product is left with only good cells. These are the stem cells, and the good cells like gamma delta T cells, NK cells, which are transferred to the patient with the graft. And this kind of graft manipulation leads to the bad cells alpha beta are removed, the good cells are retained. So immune reconstitution and the relapse rates are better. This was the landmark paper by Alice Bertina in Blood 2014. And based on this, you can see the multitude of NK cell functions, not only GVL, but also preventing GVHD by inhibiting host dendritic cells, anti-infectious immunity, most notably CM infections by these NK MSC1 mismatch on the donor cancer cells, as well as the various infections. And these kind of NK cell interventions are done by many groups in India. Dr. Suparno Chakravarti sir, Dr. Vikram Matthew sir at CMC Vellore, they are doing a pioneering work on this. So again, not only this, but the T cell alpha beta T deplete haplotransplant is a platform for adoptive immunotherapy. A lot of interventions can be dense post-transplant to improvise the outcomes. And based on this, there was a comment editorial on haplo is the new block way back in Blood 2014. So various manipulations. So T cell reconstitution is better, and this strategy you don't need any post-transplant GVH prophylaxis. And this is again a cartoon by Franco Locatelli, published in Frontiers Immunology. Very fascinating biology underneath this T cell depletion. Now, challenges in transplant, unmet needs, the toxicity of conditioning, infections, most notably viral reactivation, GVHD, and disease recurrence. And all this can be overcome to a significant extent by immune reconstitution. And this is again a landmark paper by Lancet Hematology and Cytotherapy. You can see MS cases in Dutch cohort. Those who have CD4 immune reconstitution by day 100, their outcome is more than 20% better compared to those who don't have a good immune reconstitution. This is the logic for CD45RA memory T cell depletion. Again, then on the same platform, electromagnetic beads, and the logic is the naive T cells are the primary drivers of GVHD. CD45RA are the naive T cells, whereas RO, CD45 are memory T cells. They are pushed back, they are less alloreactive, mental viral specific activity, maintain GVL. And based on this, the newer T-deplete platforms are incorporating CD45RA depletion. So the initial outcomes are very, very rewarding. You can see 80% 3-year survival and event-free survival for these transplants. So again, comparing various haplo platforms, CD45RA fares to be better than the other T-deplete haplo transplants. And you can see the number of allogenic transplants. Dr. Amit, I had how much time left so that I will quick, there are
you can take 10 more minutes.
10 more minutes, done. Thank you so much, thank you. So you can see these US NMDP, the number of transplants increasing. All the alternative transplants are again increasing, and this is EBMT. You can see the autologous transplants are on the high because of the improvement in the various transplant techniques, supportive care, and better survival. And not only that, the alternative donor transplants, notably the haplo transplants, are going high. Cord blood transplants are coming down. And in India, this was the ISCTR data, ISBMT data published last year. You can see we are doing about 2,500 transplants per year for a population such huge. So less than 5% patients who needs transplants actually get transplants in India. So it is currently limited by multitude of factors. So if you look at the statistics, more than 150,000 people in India every year are diagnosed with various blood cancers. More than 10,000 children are born thalassemics, and this number is even more in sickle cell disease patients. So you can just imagine the number of transplants. I was fortunate to be part of this group visiting China, Peking University, Beijing, China, on invitation of Professor Huang. And it was fascinating to see one center, you see, 2010, they're doing more than 1,130 haploidentical transplants at one center by their unique protocol, GISC protocol. Of course, this has not been duplicated elsewhere in the world, but they have quite promising results. So coming to taking the advantage of this, my second haplo transplant I did about 1.5 years back during the peak of COVID second wave. This is a 12-year boy, severe aplastic anemia, who has de novo osteomyelitis, hepatitis. So again, after resolution of his infections, he was taken for emergency half-mass transplant with father as donor. The conditioning was rituximab, flu-cy, rabbit ATG, 4-grade TB, and PTCY, TAC, MMF as a GVH prophylaxis. Unfortunately, he could not engraft and was, after almost 40 days, was taken up for second half-mass transplant, switching the donor to mother. And this time, again, we decreased the dose of radiation, we changed the ATG source, and we added, along with PTCY, sirolimus, tacrolimus, based on the paper published by Dr. Superno's group. So he had engrafted well. Subsequently, post-transplant was very stormy, persistent fever, progressive cytopenia, extensive ID workup negative, ferritin sky high, LDH high, fibrinogen extremely low in the absence of overt coagulopathy. So possibility of HLH. So we started him on upfront. we could not afford to lose his second graft with myelosuppressive drugs like etoposide, which are potent anti-HLH therapy, a backbone. So we added ruxolitinib as a front, and you can see with ruxolitinib ferritin nicely coming down. And as expected, in the immediate post-transplant period, you can see the CMV shooting up. So he was added on ganciclovir. Subsequently, the steroid was rapidly tapered off. So ferritin coming down to 15 again started going about 22,000, and that was the time we continued increase the dose of ruxolitinib, and as expected, CMV started shooting up, and to the point that CMV became ganciclovir and cidofovir resistant, which are only available anti-CMV drugs in India. So he has HLH with refractory CMV. Thanks to one of the great colleagues from US, whose father I treated for 8 years for primary myelofibrosis, subsequently underwent haploid identical transplant with my friend as a donor at University of Philadelphia, and unfortunately he succumbed to grade 4 GVHD. So he provided me 12 strips of letermovir and 30 strips of ruxolitinib, which saved this child. So you can see with letermovir his CMV drastically came down, and he maintained CMV quiescence throughout the observation. And with ruxolitinib, his current ferritin is close to 900, so completely normal. And it was surprising, just a month back, he passed, he was in class, I think he was in class 9, so he was 14 years, I'm sorry. So this was the boy, and he come up with the flying colors despite being absent close to a year at his school. He scored 78%. So many a times patients are motivating factors for us. So you can see the trends of autologous transplant. You see the more older patients are being taken up for transplant. You see here 36%. You see the blue bars increasing, the elderly patients, and same is true for allogenic transplant. The elderly patients, because of the various innovations, techniques, the number of elderly patients being taken up for transplant as a curative treatment modality is increasing. And this is the various graft source. You can see 61% unrelated donor, so in the elderly population. So that is haploidentical either match or unrelated donor transplants. And again, across the allogenic transplants, you can see the various donor types, and you see the green bars, the haplos are increasing over last 2 decades. Again, post haplotransplant GVH prophylaxis, you can see even now 2020 only 2% are T deplete, ex-vivo T deplete, but vast majority 91% are PTCY GVH prophylaxis haplotransplants led by this John Hopkins protocol. So historical obstacles to haplotransplant, we know T deplete GVHD and T deplete rejection because you don't give T cells. So they have high failure rates with more than 30% NRM. So how to overcome this? So the first breakthrough was haplo-PTCY, and nicely recently elaborated in 2030 journal. It was also highlighted that not only the alloreactive proliferative T cells are inactivated and destroyed by day 3, day 5 cyclophosphamide, but the TREGs, the T regulatory cells, who have inherently more aldehyde dehydrogenase, they are spared, and they are the non-proliferative, non-alloreactive cells which are spared, which are important for anti-infectious and anti-tumoral immunity. So this is the timeline of haplotransplants. So literature search, there are 1700 PTCY haplotransplant hits when I search, and more than 20,000 patients have received haplotransplant with PTCY backbone, both in adult pediatric settings. And of these, more than 1,000 have received only single agent PTCY without any immunosuppression. These are various journal publications. So how to improvise? So in fact, these T deplete haplos have increased the accessibility of haplotransplant to our elderly patients. This is again a 65-year AML patient who has a FLT3 ITD mutation, primary induction failure. His course was very stormy with periannual cellulitis with fissure in ano, and subsequently, just to buy some time, I added aza, venetoclax, midostaurin. Unfortunately, fortunately his fissure in ano resolved, periannual cellulitis settled. So subsequently took him for flag ida as a salvage. He has a very turbulent course with worsening periannual sepsis. And after recovery, I took him for rituximab FM, fludarabine melphalan 100, rabbit ATG, TBI4 gray, conditioned haplotransplant, which has his daughter as a donor with PTCY backbone. Again, peri-transplant was very turbulent, VRE, Pseudomonas aeruginosa sepsis requiring multiple granulocytes. And towards the engraftment, he has VRE and PCP meningoencephalitis. He was in deep coma, close to 11 days of ICU hospitalization on mechanical ventilation, but he recovered, and now he's 1.5 years post-transplant with manageable chronic oral GVHD. Then this is recent picture. So these kind of elderly patients being taken up for haploidentical transplant were unheard of. So you can see the survivals across the both malignant, non-malignant indications are increasing. Trends in survival. So what is the future of transplant? I will narrate in quick 2 minutes if allowed. So, the T-deplet haploidentical transplant particularly is the platform for further various immunotherapies like monoclonal antibodies, bisphosphonates, BiTEs, CD45 RA deplete, memories T cell, DLI add-backs, virus-specific T cells, CAR T cells, activated NK gamma delta cells or activated NK CARs, cytokine inducer cells, tumor-specific T cells. So basically, this is an immuno-augmenting opportunity to improvise the transplant outcomes. And how can we tolerize the T-replet transplant, the lessons learned, the PTCY, how can we incorporate in the T-deplet transplant? So you give PTCY to tolerize the donor T cells, and then you do the subsequent T-deplet transplant, and the outcomes can be really promising. Again, haplotransplant as a platform for organ transplant. This has been done successfully by Rupert Handbintinger and Alice Bertina in Sanford. You can see haploidentical, particularly pediatric population who have various inherited conditions with both bone marrow and kidney failure. The haploidentical donor, the donor immune system can be harnessed, and the subsequent solid organ transplant not requiring lifelong immunosuppression. So basically, this was as a pilot project in Sync immunoosseous dysplasia were done in 10 children. This was the protocol, and this is the survival. So first haplotransplant, T-deplete, followed by organ transplant, and these children are doing phenomenally well. So donor NK CARs against TCR alpha beta T cells, again, not the many people believed CAR is going to completely take up the transplant. It is not though. So CAR therapy can be integrated in the transplant platform for the better outcomes. So you can get away without conditioning chemotherapy, and again, these CARs can eliminate recipient T cells, not requiring any immunosuppression later. Anti-TCR alpha beta antibody, again, another approach to tolerize or deplete recipient T cells, not requiring chemotherapy, or you can give more robust doses of rapid ATG campath and subsequently anti-TCR alpha beta antibody, which can be a boon. And this is possible with this particular molecule, imlifidase, which is being done. There was a NEJM 2017 publication. This is indicated for desensitization of highly sensitized kidney transplant patients. So what it does, it cleaves the immunoglobulin. By then it also cleaves the ATG and campath, and then preventing the lifelong immunocompromising toxicity of these immunotherapies. So again, these are the future, and integrating both PTCY versus with the TCR T cell deplete transplant, you can get away without conditioning, without significant immunosuppression, with better outcomes. And rationale for engineering CAR T cells for discarded alpha beta T cells. These CAR T cells from healthy donor, with TCR knockout, they don't cause GVHD, whereas from the patient, it is not rejected by the host immune system. So you hit two birds with single, donor derived alpha beta CAR T cells. So again, autologous transplant, enormous literature coming up. The logic is tolerance, CD4 positive T cell compartment renewal, and this is the landmark US COT trial with significant improvement in autologous transplant arm compared to conventional monthly cyclophosphamide. COVID has taught us so many lessons. So COVID-19 vaccines can be developed in a span of 1 year, which normally requires 10 to 15 years. I think in science, anything is possible, and the future seems to be quite exciting. And I feel we are privileged to be in this era of the most fascinating time in hematology and bone marrow transplant. And again, this is a recent cartoon. India is 5th in the global economy. So we can't continue to complain about our inability to not adapt to these newer scientific developments. So we need to change our approach for the better chance of cure. And these innovations open a pandora of opportunities for these suffering patients. But yes, it has to be used with caution. A proper training and a proper mentorship is needed. So coming together is beginning, keeping together is progress, working together is success. All this is possible, which was a fascination some years back. Fascinating facts of science. So transplants are increasing. There are many challenges. Of course, there are many breakthroughs and approvals. So just last minute to summarize the development in the revolution in bone marrow transplant over last 7 decades, 1950s first human transplant, 1960s breakthrough in immunology, 1970s clinical BMT takes off, 1980s widening indications, expanding donor choices and non-TBI drugs, 1990s new stem cell sources, new conditionings and new indications again, 2000s again RIC regimens, rise of cord blood transplant and cell therapy, whereas 2010s is PTCY decade, PTCY haplo takes off, expanding indications and graft engineering, and 2020 is ex vivo T deplete haplos, graft engineering and adaptive cellular immunotherapies. So yes, this comes with a lot of cost, and I really apologize to the God for imposing financial poverty to so many patients. But yes, this was with the pure intention of wiping out their suffering. So with that, just a last acknowledgement. Sincere thanks to Professor Maman and Professor Naveen sir for the slide deck provided by them, and also a fantastic webinar during COVID times by Rupert Handgrittinger and Alice Bertinai at Stanford Medicine Platform. So with that, I thank for your patient hearing, and I will be happy to take any questions if there is any time left. Thank you so much.
Thank you so much, Dr. Ganesh. That was a very, very lucid presentation. What a presentation! From revolution to, bench to bedside, history, everything superb. And what a presentation, what a hard work you have done in preparing this presentation. Hats off to you.
Thank you, Doctor.
So we will start with the discussions now. I think there are no hand-raised signs right now. So we'll go with the chat box. Yeah, Dr. Mukesh. Yeah, please, sir.
Yeah. Dr. Jayeshwar, I thoroughly enjoyed your talk. And
thank you, sir.
My curiosity as a practicing pediatrician is, can you tell me data about your experience with children, both in terms of hematological, malignancy, non-malignancy, as well as equally interestingly, non-hematological indications of bone marrow transplant that you've handled? The reason why I bring up this question is, with the increasing availability of genetic testing, we're diagnosing more and more genetic disorders earlier and earlier. And the final treatment that we have for these disorders is actually a BMT. So can you tell me a little bit about your pediatric data and your vision about?
Yes, sir. So I will, thank you so much for that question, sir. In fact, across the hematological spectrum, the pediatric hematological disorders, both benign and malignant, are the most rewarding. Children tolerate well. You have seen through the journey, majority of the breakthroughs were from the pediatric population, be it these T deplete haplos and gene therapies and all. So out of 200 transplants, 62 are pediatric transplants, and I am fortunate and lucky to have survival of about 78%. And beyond transplant, as you nicely pointed out, thalassemia, sicklers, these are the unmet need in our country. So we have more than 500 children enrolled with us with sickle cell disease, and we do outstation clinics, and simple educative sessions and counseling the families can bring out a huge change in their lives, can improve the quality of life. And as you nicely elaborated, the vast spectrum of pediatric hematological disorders, immunodeficiencies, genetic conditions, hemoglobinopathies, the outcomes are getting better and better each year, each month, I will say. Thank you, sir.
Wonderful. Thank you, sir.
Dr. Mona Vijayan, your question, please.
Yeah, thank you, sir, for the wonderful presentation. So my question is, sir, so what are the absolute indications, if you feel, that bone marrow harvest should be preferred than peripheral blood collection in which conditions we should go for that?
So thank you, madam, for that question again. So the absolute conditions are the pediatric benign hematological disorders where you don't need any GVL, and GVSD is also not acceptable. So I think those are the better indications of bone marrow as a stem cell harvest as a graft source. Barring that, again, even in the haplo-PTCY platform, initially, again, the John Hopkins group, the bone marrow was the graft source. But nowadays, with these T-deplete strategies, and also even in the PTCY backbone, the bone marrow as a graft source and compared to peripheral blood as a graft source, the outcomes are almost equal. So yes, bone marrow as a graft source leads to better quality of life post-transplant by decreased chronic GVSD. I didn't had much experience, but from one patient for whom, one of my physician colleagues' wife, for whom we did DKMS mud, and surprisingly, the DKMS quoted that the donor was unfit for peripheral blood stem cell donation, but they forwarded us 1400 ml of bone marrow graft product, and that my friend's wife, high risk AML, MLL KMT2A positive, is now 1.5 years post transplant, and the quality of life is phenomenal. She's absolutely as elegant as she used to be before transplant. So I didn't had much experience. Of course, pediatric non-malignant conditions, we do bone marrow as a graft source, but it comes with its early initial cost. The engraftment is delayed, and in a country like India, where MDR bugs, mycosis, fungal infections are so rampant, delay in 1 day of engraftment also sometimes can be very, very challenging and can cost us a lot. So you have to trade off between the long-term GVSD risk versus the early engraftment with peripheral blood graft.
Okay, thank you, sir, for answering.
Thank you.
Dr. Amit, I think you're mute. You'll have to unmute.
Dr. Shruti, your question, please.
Yeah.
Yeah.
Thank you, Dr. Ganesh, for that wonderful talk. And you just, elaborated how things worked out and made it so interesting. No one else could have done that.
Thank you, ma'am.
I have a question regarding an autologous transplant. We were talking of delayed engraftment. So this month, we actually did our first autologous bone marrow transplant for a neuroblastoma child. And, the child took almost 32 days to engraft. One of the reasons was E. coli sepsis with fistula in ano and complicating it. But what I wanted to ask was what all can lead to a delayed graft, engraftment in an autologous. Allogenic, there are other reasons, graft failure, but in an autologous, what would all be the reasons?
Thank you so much, madam. That's again a important burning issue sometimes in our practice. So particularly in autologous transplant, even though viral reactivations are not that common as we see in allogenic transplant, but sometimes these heavily pretreated patients, I remember one patient who has CMV reactivation and who engrafted on day 45. Another myeloma patient who engrafted on day 42 without any, the stem cell dose was robust, 12 million per kg. And he has ongoing sepsis related to cytopenia, but we could not trace out any cause. So in autologous transplant, all these patients are not on any myelosuppressive drugs as a GVH prophylaxis. Infections and sometimes infection associated HLH, these are the only two things which I can think of as a cause of delayed engraftment. But it can be a tricky situation. In fact, I lost one autologous myeloma patient in earlier career because of we waited for till day 55 and he didn't engrafted and we didn't had a stem cell backup, and it was a unfortunate evidence. But yes, once in a while we do see, and it can be really challenging, barring the drugs, infections, HLH. It's difficult to trace out the cause for the failure of engraftment in autologous stem cell transplant.
Thank you. Dr. Amit, if you permit, can I ask one more question?
Yeah, sure.
So, and Dr. Ganesh, hats off to you. You were able to manage those two patients, two haplos, so many days of neutropenia, sepsis. I mean, I don't know how you managed it. So just a comment or a question. How did you manage to do two haplo transplants? Because for our patients, right now we have HLH, no match. So we're thinking of haplo. We can't even get through a single one. So how did you manage two haplos in, both the patients?
Yeah, madam, actually, that's, it's a credit to our entire team, our infectious disease specialist, our, ICU team who keeps rounds of these patients around the clock, our, other associated specialty support, pulmonology to mention. So, it's a teamwork. It's, I will say, we hear through literature a lot of, second, third transplant from the Western hemisphere, but for a country like ours, the tropical climate and rampant MDRs and XDRs and, construction going on everywhere, you dig out any duct, you find so many funguses. So it's a real challenge. The first patient was neutropenic 78 days and the second one was 84 days. So it was, I will say, the teamwork, and I was lucky. Thank you, ma'am.
Yeah, Dr. Anupama.
Thank you. That was a very nice talk, especially the historical aspect was very enjoyable.
Thank you.
I was quite interested to see that it seems like there's a large bulk of thalassemics that are being transplanted in India. In the UK, we are quite skeptical about hemoglobinopathies having, going through transplant. Of course, I know you just answered about the pediatric population, but I mean, we deal with a lot of adult sickle cell patients here. And our results with the adult sickle cell patients have not been that great. So I wondered what was your experience with that, and in terms of mortality and morbidity, how did it fare?
Madam, thank you so much for that question. But, an honest confession, I had just done a handful of transplant for thalassemics, and maybe I had crossed double digits for sicklers. A significant amount of work on thalassemics is being done at CMC Vellore by a group led by Professor Maman Chandi, Sir, Dr. Vikram Matthews, Dr. Biju George, and they have very promising results. In fact, they have their own, thalassemia risk stratification of the patients for transplant. So anyone who is above 5 years automatically falls into high risk group because of the amount of care prevalent in our country. So yes, a lot of the pioneers in our country like CMC Vellore have a huge experience of transplant. In fact, the transplant took off in its real sense in Vellore through this collaborative project with DBT, with so many thalassemics being enrolled, and subsequently now the lot of NGOs and CSR activities like Coal India with the various hospitals, the lot of thalassemics are being enrolled for transplant as a curative treatment, and then they have experience of hundreds of patients. So my experience, I had done transplant for class 1 and only one class 2, and with the triosulfan based conditioning, thiotepa triosulfan based condition, and so the improvement in the supportive care, and mostly the the hepatic VOD, the hepatotoxicity is high in thalassemics. So the advent of these novel drugs like triosulfan, thiotepa has really made a mark in terms of improvising the outcomes of these thalassemia children across the globe.
Thank you.
Thank you.
Thanks.
Dr. Omkar, your question, please.
Yeah, thanks, Dr. Ganesh, for that beautiful historical review of the transplants. I must admit that even during for my exams, I had skipped that chapter. So it was fun listening to you today. For the first time, I could go through the entire journey. So I have two questions, if I'm permitted to ask.
Sure, please
The
go ahead.
first, yeah, the first question is for sickle cell patients, sickle cell homozygous patients. This was in fact a question which was asked to me by three of my questions. Now they are sickle homozygous. They do not have a matched sibling donor. They have they have a matched donor which is unrelated donor, and all three of them had put forth this question ki, because the Indian sicklers are not as severe as we see in the African continent. The African sicklers are very severe as compared to the Indian sicklers. Is the pre-transplant, extensive pre-transplant immunosuppression needed for Indian sicklers? I'm referring to this question in terms of two conditioning regimens which we see. I mean, in our own country, we have one center which is using an extensive pre-transplant immunosuppression with fludarabine, with cyclophosphamide and dexa, with augmented John Hopkins conditioning with rabid ATG, thiotepa, fludarabine, cyclophosphamide, and TBI, and then post-transplant cyclophosphamide and sirolimus. Whereas another conditioning regimen which we have been following for a very long time is a standard conditioning regimen with thiotepa, triosulfan, HOS ATG. So the question is it really needed that extensive pre-transplant immunosuppression in Indian sicklers when the sickling part is not that severe, and so the complications arising out of that also may not be that worrisome.
So thank you, Dr. Omkar, for that question. First of all, again, an honest confession, I had done only a handful of transplants for sicklers, and my great friends, you can call them phone a friend. So for all pediatric transplants, I owe them all my successes, and whatever little mistakes are there, my own ignorance. So Dr. Satyendra Kateva, Dr. Satya Yadav sir, they have a huge work in thalassemia haplotransplants, along with Dr. Sunil Bhatt from Bangalore, and Dr. Gaurav Kharia has a phenomenal work in sickle cell disease haploidentical stem cell transplants. In fact, he has a series exceeding 50 patients, and his paper is one of the most quoted haplotransplant across sickle cell disease. So pre-transplant immunosuppression, for these all hemoglobinopathies, irrespective of the moment these patients are considered for transplant, that means they are eligible for transplant because of their disease severity, right? So when they have such a severe disease and they are being taken for transplant, the graft rejections, the post-transplant HLH is huge if you don't do PTIS. In fact, we have burnt our hands initially when the initial papers didn't come. But so I think Dr. Kateva has done more than, my close friend Dr. Satyendra Kateva has done more than 50 haplos for thalassemias. So his experience, his PTIS is really helpful in improvising the outcomes, and also so is true with Dr. Sunil Bhatt and Dr. Gaurav Kharia for all sicklers and thalassemics. So that logic that Indian sicklers are not severe, the moment they are considered for transplant, they are severe.
Okay, so this takes me to my in fact the first question I should have asked you. Nowadays we are offering transplants to our sickle homozygous patients even at the age of 3 and 4. Which we never did before, because hydroxyurea has been a wonderful drug. And then we were always of the belief that they don't need transplant so early. But now there is data which is supporting early age of transplants in sickle homozygous is always better than doing the transplants once they come up with complications. So in that scenario, the second question, the first question which I asked you, in fact, has been put forth by three of my patients who are 3, 4, and 6 years old, who have a match unrelated donor. And that is how the question in fact had come. So the question is, which is the right age of transplant? And for sickle homozygous, that's one. And second, even for non-transfusion dependent thalassemics, who eventually land up at the age of 16 or 17 to us with complications of chronic hypoxia. So is it imperative or is it wise to push them for transplants early in their life?
So I will take your second question first. So non-transfusion dependent thalassemics are thal intermedia, and there are enormous interventions which holds the promise of improving their outcomes. So simplest one is IMIDs like thalidomide can really increase their hemoglobin apart from hydroxyurea. So you know, at the when they present at the age, you know, first beyond first decade, they have, if poorly managed, lot of iron overload associated organ toxicity. So transplant is very challenging, number one, and his outcomes are dismal. And when the other contemporary novel drugs can give you a better result, so why should to consider them for transplant, the thalassemia intermediates. And coming to sicklers, now with regard to sickle cell disease, what is the earliest age to consider transplant? So the literature shows the moment sickle cell disease patient develop any organ damage, the outcomes drops down to less than 50%. So be it you know, pulmonary hypertension, cardiomyopathies, or you know, avascular necrosis of bones, outcomes are dismal. So the patients who, there are set criteria for transplant in sickle cell disease, more than 2 vaso-occlusive crisis requiring hospitalization in previous 12 months, and so any CVA, uh, uh, and these are the patients who should be considered for transplant earlier. And nowadays the outcomes of even PTCY haplo for sickle cell disease are so much improving. The curves are coming up matching the MSD transplant. So letting them develop the end organ damage and then ending up with suboptimal outcomes, it is better to consider them for transplants earlier. Again, a word of caution, there are a lot of other non-transplant interventions like novel targeted drugs are coming in sickle cell disease, which might improve the outcome and which might I follow the philosophy of my mentor, Dr. Maman Chandi sir, a thalassemia major. If you take the cost, lifelong cost of the care, conventional non-transplant care, and added to that is their lifelong suffering and the pain of transfusions and all these compliance of drugs, even with the optimal drugs, many a times, you know, outcomes or their developmental milestones are not up to the mark. So why deny them the opportunity of a completive curative treatment modality, that is the hematopoietic stem cell transplant? The outcomes are improving. There has been phenomenal you know, progress in terms of supportive care, conditioning chemotherapies, long-term follow-up, long-term outcomes, GVHD prophylaxis. So all the aspects of transplant are phenomenally evolving for the betterment. So both ways, again, you have to trade off between the possible management in the conventional non-transplant arm versus the potential cure offered by the transplant in these patients.
Okay, thanks, Dr. Ganesh.
Thank you.
Thank you, Dr. Omkar. We have a question from the chat box. Dr. Karan wants to ask that he has noticed that your haplo, you said that combining ATG plus PTCY, is it required? And second question is, what is the indication for rituximab in haplo conditioning? Is it to reduce EBV?
So rituximab, I will take the first question. For the second question first. Rituximab is for EBV, so CD20 depletion, more so in the PTCY backbone, because once patient develops EBV, you don't have definitive therapy, barring EBV specific adaptive T cell therapy, which is cost a shell, shell of a bomb. So the first question, the ATG, you know, I mentioned in one of the slides the barriers for success of haploidentical transplant. T-replete transplants is graft rejection, GVHD, and T-deplete transplants is graft rejection. So, you know, both ways ATG helps. So ATG as a polyclonal immunoglobulin, depending upon the timing and dose of the ATG, it can help you getting better engraftment and also decreasing the rejection chances and also decreasing the long-term GVHD outcomes.
Thank you so much. Dr. Ketan Modak has a question. Letermovir has been approved for prophylaxis. Can you use for therapeutic purpose? And second
Absolutely.
question
There is
he has that is agent like Marabivir available in Indian market?
neither Letermovir or, to the best of my knowledge, Marabivir not available. And Letermovir, as pointed out, is both for prophylaxis as well as therapy. So we have a living case with us. The cost is huge. If you import, per strip is about 10 to 12 lakhs. So, fortunately, we had a drug stock of about more than 1 CR, thanks to my friend, hematology friend, who has donated for poor patients.
Thank you. Dr. Dibyendu has a question, how to monitor immune reconstitution post-transplant? And is it routinely performed?
Yes. So for most of our transplants, we do CD4 immune reconstitution, CD8, and there is, NK cell. So many commercial labs are doing a comprehensive immune reconstitution panel. So for match sibling transplants, uneventful course, we do at day 100 and at 1 year. But for haplotransplants, if the patient has recurrent opportunistic infections, we do more often.
Thank you. Dr. Srinivas Rao has a question that what antibiotics should be avoided after transplant if the patient gets infected?
What I'm sorry.
Avoided. What antibiotics should be avoided after bone marrow transplant if the patient lands up into some infections?
Practically, we use all the antibiotics, but our first starting antibiotic covers a broad spectrum. So we don't use the, chloramphenicol is now outdated, and also, the fear of myelosuppression. We avoid linezolid for gram-positive coverage. Number one, it is bacteriostatic and it is myelosuppressive. So with the fear of delaying engraftment or suppressing the engraftment, we avoid linezolid most of the times, and chloramphenicol is for most of us, it is outdated now.
Thank you. Dr. Gayatri has a question. What is the success rate for bone marrow transplant in patients suffering with X-linked agammaglobulinemia? She has an 11-year-old boy case right now.
X-linked agammaglobulinemia, the success rate at 11 years, the child must be having a lot of invasive mycosis, lung infections, sinopulmonary infections. So the infection associated lung damage and deeper infections with organ dysfunction can jeopardize the outcome. But yes, X-linked agammaglobulinemia, again, just like thalassemia, 2 options: lifelong immunoglobulin replacement if the family can afford and can be very compliant, or else the transplant at the earliest possible time for the best possible outcomes. Again, honest disclaimer, I am not a pediatric transplanter. I owe all the pediatric transplant to my, I try to do, but it's all through a lot of discussions through my pediatric colleagues. They help me a lot. It's a phone call. So Dr. Satyendra Katewa, Dr. Satya Yadav, Gaurav Kharia, and Sunil Bhatt. Thanks to them. I'm not a pediatric expert, but yes, we do pediatric transplants, having first-hand experience with manageable, mild to moderate cases, not severe cases.
Dr. Radhika has a question. 9/10 mud CLL mismatch versus 6/12 sibling. What would be your preference for an 11-year-old aplastic anemia?
That depends on which locus is mismatch.
CLL mismatch.
HLA-C mismatch.
HLA-C.
So again, for aplastic anemia, even for match sibling transplant, there is evolving literature of PTCY as a better GVH prophylaxis backbone. Of course, comes with a cost of delayed immune reconstitution and more opportunistic infection. But any major mismatch, ABC, DQDR, barring permissi DP B1 mismatches, I will consider these patients for PTCY GVH backbone transplant, just like I will do for haplotransplant. We have 2 transplants, one HLA-C mismatch, DRB1 mismatch. We because of various reasons, one patient with DRB1 mismatch has AKI right on day 2 with severe neutropenic sepsis. He came out of AKI, he engrafted, but he died on day 134 with grade 4 refractory gut GVHD. So any major mismatch in aplastic anemia, my personal experience is bad, so I'll take him for PTCY GVH backbone, GVH prophylaxis backbone.
Thank you. Another question from Dr. Debyendu Dey. What protocol can be used for haplotransplant without TBI?
So we do for many, thiotepa is a radiomimetic drug, and there has been huge literature, particularly in T-deplet transplant and children below 3 years of age. We still use thiotepa based conditioning. So yes, we can replace thiotepa 10 milligram per kg for TBI. I had done 3 transplants of children below 3 years. So fludarabine, melphalan, thiotepa, rabbit ATG, and 2 of them are doing well.
Thank you. Dr. Anupama, you have a question?
Yeah, I was just curious to find out, like, how good is the DLI, the donor lymphocyte infusion access in India? Do we get the donors coming back to donate, or what is it like?
Yeah, it is absolutely, madam. So in fact, many of our senior mentors are even doing prophylactic DLI for high risk hematological malignancies like AML and ALL. Dr. To the best of my knowledge, I remember Dr. Suparna Chakrathi and Sarita Rani Jaiswal doing a trial, institutional trial of prophylactic primary prophylactic DLI starting at day 60, day 50 or so for high risk malignancy. So DLI, yes, donors do come back, and it's just a matter of unstimulated T cell collection. In fact, with the advent of course, the cost is a barrier, but the literature of CD45 RO add back DLI is very, very promising for high risk malignancies and refractory malignancies.
Sure. Thank you.
Thank you.
So anybody has any other question? Because we have finished all the questions from the chat box. So if no other question, thank you, Dr. Ganesh, so much. Your presentation, your discussion, your session was excellent. And I don't know how wonder you make this presentation. Every time when I see your presentation, I'm just a fan of your presentation.
Thank you.
Excellent, superb, fantastic.
Thank you, Dr. Amit. And again, I'd like to take this opportunity to thank our mentor, Dr. MB Agarwal sir, for his relentless efforts to continue these academics. We all wonder how he manages such a hectic academics on a regular basis for close to more than 3.5 decades. So thank you, Agarwal sir, for this opportunity, and I'm really privileged and honored to be a speaker on such a most reputed MSG platforms. And I remember during the COVID first lockdown, I had a discussion with MB Agarwal sir about possibility of starting a Sunday webinar, and sir has agreed to it, and today it's a very successful, most sought after, talked about webinar program, not only nationally but internationally. And I'm really thankful to sir for all these opportunities. Thank you, all of you, for sparing a busy family time on a Sunday, and thank you to one and all for this opportunity. Thank you. I hope my literature search would have been little beneficial to all of you in the field of transplant. Thank you. Take care. Goodbye.
Absolutely. Thank you so much. I now hand over to Nirvin Life Sciences for the final vote of thanks.
Thank you for the fantastic session, Dr. Ganesh. It was really amazing to hear your experience and knowledge. And I'm sure it will be really helpful to all the participants of this webinar. Thank you, sir. Thank you to our chief guest, Dr. Professor S.P. Verma, our moderator for today, Dr. Amit Khurana, for a fantastic moderation, all the eminent discussants and participants of today's webinar. Finally, a big thank you to Professor Dr. M.B. Agarwal and MSG for making Nirvin Life Sciences part of this amazing webinar, and also Perfect Square for conducting this webinar professionally. Thank you all. Have a nice day.
Thank you. Thank you.
Thank you. Thanks a lot.
Thank you.